All right. Thank you, everyone, for joining us this evening. Tonight is going to be all based on the Phantom Lapidus nail, and Dr. San Giovanni, thank you so much for joining us. For those of you that don't know, Dr. Thomas San Giovanni is based out of Miami, Florida. He is the Fellowship Director of Baptist Health South Florida. He's been instrumental in the design of the Lapidus nail, and he's helped us out a great deal over time when it comes to figuring out how to progress this system and make it as good as possible. So tonight we're very honored to have you. So I'll hand it off to you, Dr. San Giovanni, and we can get started.
Great, thank you, Alfred. Welcome everyone. Yeah, this is a procedure that I think is a substantial innovation, at least within my practice, that I've been able to enjoy over the past year and a half or two since it's been released. And I'll go through a little bit about my evolution towards this procedure, because it wasn't let's say a direct a direct love, let's put it that way, in terms of the Lapidus itself. Let me see if I can advance this here. You know, in talking about the Lapidus, the name is thrown around a lot, and I always like to go back and take a look at who was the first to describe this, because just to pay some type of respect. And Paul Lapidus was one of the first, let's say, within the American Orthopedic Foot and Ankle Society, which had grown from a group of 5 members, and he was the program director at Hospital for Joint Disease in New York City. And out of that institution, there tremendous amount of foot and ankle, let's say, contributions came from him and Mel Joss and many others. So this is somewhat of a mecca, let's say, of foot and ankle at the time, and still to this day, it's very well recognized and respected institution. I said this was developed. His procedure was developed for correction of hallux valgus deformity. It was essentially to realign and stabilize the first tarsometatarsal joint via an arthrodesis procedure. Something that had not been, let's say, described before, and it has gone through many different modifications over the years. So what you see as we've come to this stage is this is like the 6 or 7 different modifications. Essentially, pins were first used, and then cross screws, and later in the early 80s, Kenny Johnson established putting a screw across the first and second metatarsal to try to help additionally stabilize that joint to get an arthrodesis. So this is, once again, it's not it's been an evolution of a procedure itself to get us to this stage. One thing that we do know is not all hallux valgus deformities are the same. So we have to have let's say a surgical armamentarium to be able to tackle all these different types. There's so many different procedures for hallux valgus, and they seem to be growing. We obviously, as surgeons and as human beings, have our own preferences, and that's natural. Those preferences can really be from anything. They could be from your own experience, whether a good experience or bad experience. They could be from just, let's say, familiarity or ease of let's say, performing the procedure, certain types of hardware, and obviously the results that you get. In the patient population that you work in, could also give you, let's say, lean you one way or the other. So all these factors come into play in terms of decision making for hallux valgus. When it boils down to it, probably most of us probably have somewhere between 4 or 5 different procedures at hand that we tend to go to. You know, whether it's an Aiken or some type of biplanar osteotomy of the proximal phalanx, or distal metatarsal osteotomies, soft tissue realignments, osteotomies of the metatarsal, and once again through the medial column and the first TMT. So you have to have all these at hand. Like I said, when I passed through my fellowship, I would have to say that we did not do a lot of Lapidus procedures, so I was not really comfortable doing them. There seemed to be several different camps. There was camps of, let's say, proximal osteotomies and distal, and then there was this camp related to like a first TMT Lapidus procedure. So I didn't do many during fellowship. So obviously my preference was not to do them. I looked at every reason not to do an Lapidus, right? So I did my fair share of osteotomies, and proximal osteotomy was what we used for a wide intermetatarsal angle. At the time, a concentric proximal metatarsal osteotomy was what was hot, what was being done, let's say. But in doing so, I noticed that a lot of, I did have my own set of complications coming out. We had dorsal malunions, you had some non-unions, you also had recurrence of the hallux valgus deformity. Placing that screw with a very small window was also challenging. So there were many different things that, even with a proximal first metatarsal osteotomy, was not easy just by the way of the procedure itself. So many of us have, our decision making in terms of what we do with a wide intermetatarsal angle. Some never do a Lapidus, right? Some always do a Lapidus. And like I said, some of us will choose cutoffs in terms of ranges, like greater than 15 degrees. A lot of people will use, some people will have a range between 12 and 15 for intermetatarsal angle. Whereas others, myself, it's more a certain range and a certain patient. And some of it is radiographic, but a lot of it is clinical. So, when we're trying to assess, let's say, I'm not sure if this is just showing, like placing trying to stabilize that zone, because that's a non-operative form. But you realize that if a patient is, has this hypermobility, or if probably a better word would be instability through the medial column, then these are the ones that seem to be more prone to recurrence when I would do a proximal first metatarsal osteotomy. Okay, so that's what led me to say, you know what, I'm going to have to learn how to do this procedure, because it seemed like there was a subset of patients that would fail, and you don't want to have too many of those failures, because just personally you don't feel good about yourself doing it, and also you don't want to have one thing you don't want to have is a clinic waiting room filled with unhappy bunion patients that have had recurrences. So in saying that, learning this procedure was something I think that I needed to do, and now it is essentially has become probably my go-to procedure for a lot of these wide intermetatarsal angles, and an increasing number of patients that I'm identifying as having hypermobility or instability through the medial column. Now, we have to realize too that a lot of these deformities are not just angular deformities. They are in one plane. These are multi-directional deformities. And likely some of my recurrences that I probably had with proximal first metatarsal osteotomies were those in which I did not recognize the amount of rotational deformity that was there, or my balancing of the forces, whether soft tissue balancing or osseous realignment balancing, promoted or a recurrence, let's say, where it was I did not recognize that rotational aspect to it. So some of the other proximal procedures that I will use are also promo. Sometimes I'll use a modified Ludloff. a scarf, which that too is not a procedure that is one that I go to very often, in fact, very rarely, and that's also probably because of let's say the technical aspect, and I just think that there's other ways that we can do that. I did used to do a lot of proximal opening wedges, but once again, that too is only looking at one plane of forming. And many times I would have very good results, but then we would also have some of these ones that failed. So once you've decided that you are going to do a Lapidus procedure, they're different. You have to think about what your approach is going to be, the type of joint prep, and also there's obviously various hardware choices. And I've gone through many of these as well. I'd say, the approach, I'll tell you guys, is that I would initially do, and I've changed over the years, I would initially do my distal procedure first. I would do a modified McBride. I'd remove the medial eminence. I would do a lateral first web space release, like a typical modified McBride, releasing the capsule and the adductor, and then I would then do the proximal procedure. I've changed now. What I've been doing probably now over the past year, with few exceptions, but I've been doing the proximal procedure first, whether it be a promo or whether it be a Lapidus, and then at that time, then tailoring the distally what needs to be done afterwards, whether it needs, how much of a release do I do? Do I even go through that first web space? Often I don't. Now I will go medially. I'll see what type of correction I need distally. I'll remove just enough medial eminence that I feel like is necessary, and then through the joint, oftentimes I can do a pie crusting, a perforation by distracting the hallux through the first MTP and doing my release through the medial side. It's not always, okay, because I will, at times when they have a very, very long-standing contracture, have to release and do a lateral release. There's sometimes a rotational contracture at the sesamoid sling or complex that you have to release between the sesamoid and the inferior aspect of the head. But for the most part, the Lapidus nail now has really been my predominant go-to procedure. Some of the features of this some of the things that have drawn me towards this, that it tends to get excellent fixation. I mean, it's when you put the nail incorrectly, I would say that the fixation you get is remarkable. Probably the best type of fixation that I've seen in terms of doing a Lapidus. You get internal compression through the device itself. It's a great feeling when you're able to line everything up, and then internally, as you turn this one screw that we'll show you later, you get excellent compression through the arthrodesis site. These two factors, I think, have led me to lean towards this device, because one of the big drawbacks that I had with a Lapidus was the amount of time of non-weight bearing. And everybody's different, but for these, I knew that the healing time for that joint is going to be a lot different than the proximal first metatarsal. And trying to get an arthrodesis, I would keep, and this is my own, this was my own protocol, I would keep people non-weight bearing for at least 6 weeks with this. From week 6 to 8, I would, depending upon their x-rays and also how I felt in remembering the case, I would either let them begin partial weight bearing in a boot at 6 to 8 weeks, and then weight bearing is tolerated in a boot from week 8 to 12. If I felt there was issues of slow healing, then I would keep them, I would take them out of a cast at 6, put them in a boot, let them at least do some range of motion, but still hold off on weight bearing for 8 weeks. That's a long time, right? A long time. The results were great. it's a long time to ask of today's patient, let's say. I also tended to get CT scans on it, started to get CT scans on these at around the 10 to 12 week mark, also to kind of to see what my union rate was. And we all know that there are going to be some that will slip through the cracks, you know, that the x-rays look great, but they go on to a non-union. So I've been capturing these a lot with the CT scans, just to be sure. With the nail nowadays, I'll go back, with the nail, I'd say the amount of fixation and the strength and everything that we get through that, I feel much more confident about weight bearing people early with this. So I've been weight bearing them in a boot at 2 weeks. I say protected weight bearing because I will usually tell them not to do weight bearing as tolerated. I'll have them do, you know, partial weight bearing in a boot. They're not putting their full weight through it, or at least they're getting some touchdown and feel like they're making progress. So we're doing a longitudinal study, and I'm going through my typical protocol of getting CTs at the 10 or 12 week mark, so that at least I can get an idea of what our union rate is, and if this shift in protocol has altered my union rate. So, but it's made this procedure, let's say, a lot easier for me to recommend to a patient. Now, there's some exceptions that I would say that I don't use it, and obviously some would be if I felt there was a rotational component without instability, or a rotational component that I felt that could be addressed with the promo, which I think is an excellent procedure. And it's just really a matter in my mind of trying to determine which patients are going to be good promo or osteotomy type patients, and which patients are going to need an arthrodesis. And I think that's a fine line that we're still all trying to figure out, so that we at least can get some better idea about which will be a better outcome for some of these subtleties. So those are some of the exceptions I would say where I will still use a plate and screws, would be any type of revision that I'm having to do, or with or without bone grafting, because the anatomy itself may be altered, so that the sequence and the spacing of, let's say, the screws for the Lapidus nail, given either a very short segment of medial cuneiform, or a altered morphology of the metatarsal from a previous osteotomy, could change the trajectory of that screw and where those locking screws are. So I feel better about using a plate and screws for these type of revision cases or abnormal anatomy. Another indication that I definitely would use a plate would be when these people have like severe metatarsus adductus, and it's not just the first metatarsal that has that either varus or rotational deformity, but it's also the first, second, and third, right? So in those type of patients, you often have to bite the bullet, and you have to do your correction through the three tarsal joints, so as to not once again get a recurrence because of the second metatarsal being so deviated. The other thing too with the nail is, just as and it's probably true with any procedure, that I always have a plan B, always have a backup. Okay, I think that's just good, and just a good practice to be able to have that, so that you're not stuck in a bad position, say. So looking at some of the features that specific to the nail is, once again, intramedullary fixation, right? So the line of forces, let's say, that are going through that and the stress and strain that are going to be going through that osseous structure are going to be different with this type of hardware as it would be with either cross screws or a medially based plate with a transarticular screw, a dorsal plate, or even a plantar plate. So the compression that you get through the nail, once again, is excellent. it's one of these things that's a feel sort of thing, that once you feel it, sometimes you might get addicted to it. The other aspect I would say that is, besides the strength of the nail, is that there's not that prominent hardware that you'll see with either a plate or a screw that's left proud. There's many ways to get an arthrodesis. We've long before we had a nail, right? Obviously, we're doing something else, and your results may be very good. Maybe very good using cross screws or using a plate. So there's got to be a reason to change, right? So in your own mind, if there's something that you feel that is important that you would want to either try or change in your practice, that usually is the impetus to do something different. So whether it's to try to get better earlier weight bearing, or if you've had some issues with non-unions that you felt would have been changed with maybe a different fixation or joint preparation. The nail is a titanium nail. It's a 5.5 diameter nail. There are 12 nails per side. So in that set, there's actually 24 nails. Okay, there's 12 are right and 12 are left. The range, let's say, of the length of the nail is 28 to, it's between 38 to 60. I think I just lost our thing here. Let me see if I can get back. Are you all, Alfred, are you all still there?
Yeah, no, we're still here. It's,
okay. Okay.
I think, yeah, it just shut down, unfortunately. Yeah, it did.
Okay. All right, let's see if I can kind of get that back up. And let's see. Give me a second, everyone.
Something that I will mention in the time that we're waiting is if any of you have questions, please feel free to write them into the question box, or at the end we can have you raise your hand and I can unmute you if you wanted to ask a question overall.
Let's see if I can find it here. Yeah, it'd be a good time if they want to take questions as I try to find the presentation again. Let's do here.
You gotta love when it happens right in the middle of the presentation.
Yeah, yeah. I'm not sure why it came off. I don't think that's the one, Alfred. Let me see if I can see. I wonder if that has to do with work. So we're all, let's see, we're all still here. I don't know, Alfred, I'm not sure why it turned off. I'm trying to see if I can hit it back.
If you right click your keynote, does it show most recent Lapidus Nail webinar? Try and click on that one.
I wonder if it's this one or yours. That one.
You know what might be happening is it might be on your other screen. If you remember when we started, you made it bigger. So if you take 3 fingers and swipe to the left, does that do anything?
Nope.
Try doing 3 fingers swiping up.
Okay.
Keynote. So on the top there it says Keynote.
Bingo.
There we go.
You're hired.
Thank you.
I tell you, I don't know how everybody else out there, but I need like an IT person to be following me around all the time. Okay, so once again, so anyway, so it's titanium, and the increments are in 2 millimeter increments. It's the nail sizes are from about 38 to 60 millimeters, which are all that you need. There's 2 locking screws or 2 locking pegs that are proximally, and then there's a locking peg distally as well as a 3.5 screw. And we'll go over those. Looking at some of the differences between some of the dorsal plating, medial plating, and an IM nail, a lot of it is how the forces are going through that joint during the gait cycle, and also how the construct itself is able to handle that load. Whereas we know that, let's say with dorsal plating, you know, the load bearing, where you see, let's say, the increased stress is through the plantar aspect, and you can get plantar gapping. Laying the plate on dorsally, people would think, oh, gee, this is going to block, let's say, the dorsal malunions. But in fact, what's happening is it's much easier to bend and fatigue a plate in that plane, as opposed to when you're weight bearing, as opposed to, let's say, a medial plating. If you plated medially, if you turn a plate on its side thick enough, and you're trying to bend that in a dorsal plantar aspect, it's going to be much stronger, like on the medial side. The nail itself shared as more of a load sharing, and so that the stress going through that is shared by the whole construct rather than just certain parts. In designing this, we did finite element analysis, and you could see, let's say, when you had, let's say, when you didn't internally compress it versus when you compressed it, the sharing of, let's say, the load through that device was more evenly distributed throughout the device rather than when it was non-compressed. So getting compression across it also helped in terms of how many megapascals load was going through that zone. The other thing too that people would not really realize, or would not be intuitive, is one of the things we hear is, like, if you're placing 2 screws across that joint as opposed to the nail, people look at the nail and they say, wow, that looks large, you know, that's 5.5 millimeters, and that's going to take up a lot of surface area, and that surface area that reduction of surface area is going to be less bone that could unite, let's say. But it's actually, when you look at this, it's probably the more standard procedure that is out there is probably 2 4.0 cross screws, and the surface area that's taken up by the diameter of those screws is actually 20% greater than that would be for the nail itself. So when we look at that, that's also so the argument against, let's say, using a nail because of the size of it is actually doesn't make sense in terms of what most people will use. The other features, once again, were sustained compression, possible early protected weight bearing, and the variability of length that you can use. Looking at part of the procedure, you know, surgical technique. Some of the instruments that we have on the set and that you use are this, which is a joint. We have a joint preparatory chisel. we have something that's called the Lapidus nipper, which you can grab, let's say, the metatarsal side of the arthrodesis after you've made, let's say, a cut, and then also like a perforating drill bit. This is nice. I use this a lot, even with other procedures. In the arthrodesis procedures I'm using for even the hindfoot and the midfoot. Nice that the drill bit itself, it doesn't generate as much heat as you would with a K-wire or a pin, and the stoutness of, let's say, this barrel also doesn't. You don't have the problem with the drill bit breaking. So it's a nice little feature that I love. The other aspects in terms of the procedure itself, and kind of run through this, and I'll show you intraoperatively as well. But the realignment, when you do the realignment, I also dial in some rotation. What I try to do nowadays is I'm trying to get the sesamoid complex to sit underneath the metatarsal head where it looks neutral. Okay. In doing so, you're almost always doing some degree of rotation, and so obviously supination, and trying to supinate and trying to abduct the hallux, and then once again getting compression. So this maneuver that you have to do to get this lined up and also to get it compressed with the right rotation is the key to probably the ultimate, let's say, alignment in terms of like trying to avoid recurrences. The other thing would be the way you do your joint prep. There's people that like to do wedge cuts, and then there are people that don't. Okay, and it's really, some of it's preference, and other it's whether you rotate and translate for different things. I predominantly don't do wedge cuts. I predominantly just try to denude the cartilage and get into the subchondral bone so that I can feather it. I try to get some. I try to preserve the length that I need, let's say, without shortening too much. But you do have to do a very good joint preparation. Otherwise, no matter what hardware you use, the union is going to be based on having good cancellous bone against each other and having good compression across it. So I can't say I never do wedge cuts. I do occasionally, so that's important. Let me go back. So once you've realigned it, realignment, you provisionally pin across the joint. I will check under fluoroscopy if I have the sesamoids lined up. I will also make sure that I haven't translated the metatarsal dorsally, that everything looks like it's where I want it. Once I like the position, we place something called a spherical wire. It's like a little ball pin, right? And this is going to be the target where you're going to try to be placing the guide pin across the joint and try to hit the tip of it. So placement of this pin, the spherical wire, let's say, is essential. The proper placement in terms of the placement of the nail. Where you want that is along the proximal plantar aspect along the medial cuneiform. So here's your navicular, here's your medial cuneiform. You want this on the plantar aspect proximally, so that it is just distal to the navicular cuneiform. Okay? So you're trying to hit this bullseye. So you want to kind of be right in this position. Oftentimes when you try to get a lateral view on fluoroscopy, you don't get a good profile of this bone. So what I typically do is when I do the lateral view, I just gently internally rotate or adduct, kind of adduct the foot slightly. And then once you do that, you get this nice profile. So it's just a little tip and trying to get your proper fluoro shot to know where you're at. But that's the ideal location. You also want to make sure that when you put that in, that little pin in, that is going to be placed perpendicular to the cuneiform. Okay, so if it's angled too much this way, it's going to when you put your guide pin in for the nail, it's going to be off. If you put it too much towards the navicular cuneiform, okay, then your guide pin may be coming in too medially. So it's important to kind of make sure that you place that perpendicular to this. This bone can sometimes be soft. So you want this collar, right against that bone, but you don't want it deep. So here's one instance where when I put it in, it's a little deep, and you see the deeper you put it in, the more lateral, right, translated the pin's going to be. Now in this case, it was fine, but I just want to make sure that you guys realize some of that bone. Sometimes that bone is soft, and it'd be easy to plow through, right? And you want to have this so that it's against the bone rather than sinking it too deep. Once you've got the spherical wire in place, and oftentimes, like I said, I just do that right percutaneous to the skin. Then we'll measure from the measure from the joint on the dorsal aspect. You want to be at least 23 millimeters. So we have a nail positioning guide that will hook into the joint, and when this is placed, you want to has a right and left, and you use like the ink marker, and you put your little dot there. It's got to be at least 23. I shoot for somewhere between 23 and 25. You don't want to be proximal to that, because it's going to affect your trajectory of your nail, and your nail may be coming in too steep, okay? And also you risk the chance of cracking through the dorsal cortex here. So once again, make sure that you're at least 23. Like I said, I shoot for around 20, anywhere from 23 to 25, preferably 24. That was Willie Mays' number. He's one of my favorite baseball players. So, going through, once you place once you place your mark, then there's something called a polyaxial guide that's in the set, and this little claw will clip into that spherical guide, and then you can pivot this in any plane, and a guide pin is going to be directed to hit that tip. So depending upon where your starting point is, this will hit that tip. That hits it probably 95% of the time, but 5% of the time it may miss it by a little bit, and that may be either some alteration through here, or it could be one of your provisional pins, whether you use one or two, may glance or may deviate the guide pin that you place in because it's riding against it. So once again, make sure that your temporary fixation pins are out of the way. If you have to change one of them or two of them so that you kind of get this in a better position, then you have to do that. Looking at, once again, proper placement, right? And once again, you can put this provisional fixation pins in any direction that you decide to. The key is that you're trying to hit that tip and that point. The other thing I'll tell you is on the AP view, remember the inferior aspect of the cuneiform rides, the plantar aspect, let's say, comes pretty proximal. So it may look like you're in the joint, but you're really not. So check your lateral, okay? But just so you know, in the anatomy, you might have to get a different projection if you're not sure, to make sure that you're not in the joint. But it's just once again, just kind of knowing the shape of the morphology of these bones that we're dealing with, and how you get an X-ray. There's a pin on the set that's a 2.3 millimeter guide pin. It's got a spiked tip, so you'll see it's different than the other. There's another one that's on there, 2.7 millimeter, which is used for these threaded pegs that you'll put in for the interlocking screws. Okay, but the one on the set for the guide pin for the nail is a 2.3 millimeter. And another thing that can happen is when you're placing this, that pin will often want to skive. Okay, that's why that tip is a little different. So sometimes once you make your mark with an ink pen, you may want to just spur out a little pilot hole so that the tip of that guide pin will at least catch rather than skiving across the dorsal surface. This is once again kind of looking at that. One thing I forgot to mention too is that you're putting that nail positioning guide at the mid portion, midsection of that joint, and it's purposely set so that it is off slightly lateral to midline, and that just happens to be the trajectory that we would say would be ideal for placement of the rod. I mean, the placement of the nail. Okay, so just off slightly lateral is going to be kind of the starting point. You don't want to get too lateral, but like I said, that's what we've determined has been ideal. Once you place
Dr.
the guide pin. Yep.
A question that I got, I think it's a really good spot. Before you drill and whatnot, do you have any advice on how or where you would best place the provisional wire in order to avoid all of this? Because we're only using one, right? Do you have any tips on where you place it every time, just to avoid the whole construct as you're drilling and placing the nail and whatnot?
Yeah. I will sometimes place it percutaneous through the plantar aspect, okay, and run it up from there. And then I typically will place a second pin, right? And these are like we could place a 6-2K wire, and that 6-2K wire will often come just off dorsally. So I'll place it either proximal dorsal, okay, across slightly obliquely to capture from the cuneiform into the metatarsal. And by placement of the two, that means I can remove one of them if it seems as if the guide pin is hitting one of them and deviating. So it's not uncommon that you have to do that. So those are that's how I usually place it.
Okay, thank you.
Yeah. Once you've then you'll drill with a 5.5 millimeter drill, cannulated drill, and then you after you've measured with the depth gauge, so you'll measure, you'll drill, and then you have to place the nail, and probably go over the technique guide so that you and your scrub tech are, and also the reps. So the reps out there, it's very important to kind of know and get familiar with kind of setting this up. It's not hard. Right? It's just a matter of just kind of knowing the steps. So it comes with an outrigger, which is just here. This is the slider, outrigger slider. And these are color coded. This is always purple, the outrigger. But the outrigger slider matches the length of the nail. Okay, and it goes by two nails will have the same. So like let's say a 38 and a 40 will be a certain color, and a 42 and a 44. So, and that should match nail. Also make sure that it's also side matched. So make sure that if you're putting in the right nail, right, that it's also the outrigger is also, the slider is the same. Okay. So you got to make sure that the double check with the scrub tech that they're loading up the right nail. Okay, this you insert the outrigger slider, and then there's a thumb screw that will attach the nail to the jig, and you'll tighten that thumb screw. That's right here, and that will make your attachment. You also want to make sure that this here is not already compressed. You want to be able to compress with this screw. So you want to make sure that this is loosened so that when you place the nail, then you can tighten this to get internal compression. And this will become, once you've done a couple of these, it's become self-explanatory. So once you place the nail, you want to place the nail so that this collar is seated down so that that gold portion at that interface is flush with the bone or slightly countersunk. Okay, You don't want it so that it is proud. Okay, so you want that to be flush or slightly countersunk. Once you've placed it, then you're going to assemble the guides for the proximal threaded pegs. At this step, we'll usually put the lateral one in first and then this one, but it really doesn't matter. But you want to put both pins in before you put one of the screws in. So this has a sleeve, an obturator. Oftentimes you can do this through the initial incision. Sometimes you can do it percutaneously. I like to see it, so if I have to extend the incision a little bit, I do. But I tend to like to see it rather than doing it percutaneously, especially this one here. I worry about the tendon. Another thing that can happen at this stage is while you're putting the obturator and everything in, and you're getting this seated, right? Be careful that the nail hasn't shifted back. Okay, and I say that because obviously it's happened to me. We're concentrating on this, and then as you're concentrating on this, and you're trying to fiddle with trying to get the skin kind of retracted back, that this is backed out a little bit. And when that does that, and you put these in, you want to just, once again, just double check once you've had these, right, before you put the pin in, let's say, right, you got the obturator down, just make sure that this is seated once again so that it's flush to slightly countersunk. It's just a technical pro. Okay, you want to place both pins in the guide wire. You measure with a depth gauge, and we'll place two of the threaded pegs here, 3.5, and then once you've had those pegs placed, approximately, now you can compress. And how you compress is there's this little screwdriver will fit into this, and you're able to compress manually, and you'll get excellent compression through that device. As you do that, you can continue to tighten. Now, how much compression is too much compression? Is there too much compression? There is some papers on what's the optimal amount of newtons per Newton force that you want across an arthrodesis site to cause necrosis. It's been extrapolated to approximately 80 to 100 newtons. But we're not sure, but that's from some of the literature and what we've extrapolated that data. So there is a torque screwdriver that you can use as well. That as you can use that as a guide in terms of when to stop. But you continue to get excellent compression. We'll show that. So I performed this in the lab, and then obviously in the cases that I've done, which have been substantial now, you'll see that in each case you should get that. So once you've compressed through the device, and then you're going to place a medial to lateral threaded peg as your distal fixation, and then ultimately there's this. Then you remove the jig, and then there's one more screw that you can place that goes through the very end of the nail. This shows the compression. This shows removal of the device, removal of the obturator. Of the outrigger. You got your two screws here. You got the one screw coming across here. And once you've removed it, then there's a threaded drill sleeve. You'll place the 2.7 millimeter K-wire as a drill, and then you'll place that final screw. That gives you your final fixation. And this is what the construct will look like. Remember that the joint itself, right, is here, right? This is after it's been compressed. There's been, oftentimes you'll see like what looks like a joint line here, but what you're looking at is the second TMT. Okay, so remember, second TMT is set back from that of the first. So when you're looking at laterals and when you're looking at, let's say, your post-op 2 week, your post-op 6 week, remember that where the second TMT joint is. So if you see a line that looks like a gap here, so you're probably looking at rather than your first TMT. This is just showing there's a certain case, looking at the deformity that you see. Once again, this is prior. I've started to just do the proximal first, unless they have really severe contraction. Then I'll make my medial incision. But like I said, I'm doing that less and less. Is it Alfred? Is the volume playing on this or not?
Yes, it is. I can hear the video.
Okay. Yeah. So I apologize for that. I don't know how to stop that. But
it's not really that loud.
Showing,
so it should be okay.
Okay. Okay. So this is showing like the typical approach that we're using. And it's kind of going through, and I'm kind of centered over the first TMT. Now, having said that, I am excited going forward. Is that I believe that our joint prep, which is critical stage, I think that may be that what's coming around the corner though is probably some MIS jigs that I think that we're working on. I think Dr. Guyton has helped design a jig that we probably could be doing a lot of this through very small incision, just for joint preparation, and then realignment. So using like a small jig and either like cutting saw or burr, some type of burr that will be helpful. So I think that will be something to be looking forward to. This is just showing other joint prep tools. This one's called the I found these very helpful because, like I said, I've been getting away without as many wedge cuts. Oftentimes you'll make a wedge cut and sometimes you take too much. So this one's called the Honey Badger. That seems to work very well on the concave surface of the joint. Right, you can kind of see that you kind of use it almost like an elevator. Right, it's got a sharp edge to it, and then you're able to really kind of take off that cartilage. Now, I don't just stop there. I'm still going to be, I want to really get past that subchondral bone, that hard subchondral bone plate. But it does speed your time, in terms of like getting this thing, getting the joint prep going. Like I said, that's probably one of the most important stages. There's other devices called the Barracuda, right? And it's just basically I use this on the convex surface of the joint, just by the way the cutting edge is with that. Anyway, so these things are great. I tell you, even for like your hind foot, like your subtalars and your talonavicular joints, it helps you speed time. Once again, making sure that you realignment, right? So oftentimes I'm bringing it into supination, abducting it, making sure that I'm not translating dorsally, and I'm either lining it straight up, or if anything, slightly translated plantar, but I kind of line it up, and I'm making sure that the metatarsal is not being translated dorsally. This too, I'll say too, sometimes you get blocked. Like sometimes you cannot, as you try to abduct it, it won't do it. And you're getting blocked either by the facet here or the second metatarsal. So I will sometimes take a saw and just make a little chamfer here, right? Kind of slightly oblique. Or, so that when I rotate it, and so I'll make a little chamfer there, and then I'll come a little bit straight down. And then once I'm able to do that, then I'm able to pivot it better and translate it. And so taking that little wedge out, and now all of a sudden, now I have it lined up the way I want it. Okay. So it's not every case, but it is oftentimes you'll have to do that. Then once again, I get into provisional fixation. Right. This time I just put it here. Let's see. I don't know about everybody else, but I'll tell you this. That's one of my anesthesiologists. So we have some comical anesthesiologists, unfortunately. But so then, and this is showing once again you have your provisional fixation, right? You'll see here later probably that was not the ideal spot, because as I line this guide up, this got in the way, right? So you can cut that short, or you come in from the bottom and have another one from this side. This is showing placement of that cloth, right? And then we've gotten, so once again, I've gotten it, so we've placed the sphere, we've made our point, we've marked it, right? So once again, it's about 24, 25, let's say 23. Okay. And once we start doing this kind of more MIS, you're gonna just have to make a little incision here, and then here we could probably make a very small incision too, and making sure just to move the EHL out of the way, and that you're protected with the drill sleeve. And this is showing placement of the guide pin. Once you place the guide pin, you've measured with the depth gauge, right? We've assembling this thing. So once again, it's an assembly. You can go through all that. So once again, these are color coded. This is showing you that we want to make sure that this is loosened up so that you'll be able to do the compression, right? And then you have to set this up with the collar and use the thumb screw to kind of tighten it.
Yeah, I'm recording.
It's showing placement of the nail. So now you've drilled it. You've already drilled it. I'll bring it down. Once again, you want to try to get that so that the collar of this is all the way down, right? Usually you can just slide it in just like that, kind of just rotating a little bit. You have to tap it in a little bit. You have to. But like I said, once you've done that, make sure that that's seated down. And when you put these obturators to these proximal drill sleeves, make sure that this hasn't, backed out, because your assistants are going to be pulling on the skin. They're going to be trying to kind of, so that you can get these in. And just don't lose sight of that, because that's technically, you don't want to see that thing is proud. So now you've placed the two proximal ones. Once again, you maybe drill, measure with the depth gauge. Hopefully this will show. This is now that we've got our proximal fixation, try to look into this right here. This is going to be where the joint surface is. I'm going to try to show you.
You're looking down upon it.
The compression. Hopefully you'll be able to see as you tighten this. Using the ratchet thing. I'm not backing it out. But you really can get, like I said, you can really get very good compression through this. So you can use a torque. You can use a torque thing, or you can just do it by feel. Once you've compressed, then you're going to put the medial to lateral threaded peg, and that's your metatarsal fixation. And then finally, once you've placed that, then the final step, going here and placing a 3.5 millimeter screw that will lock into that most distal aspect. Whether you do unicortical or bicortical, is a matter of discussion that we're still deciding. You could do either or. I tend to usually get bicortical, but like if you're worried about like the stress generated at the end of the nail, then I think you could also just put a unicortical and it should be fine. This is just showing that this case and kind of seeing like where we're at here. In this case, you did have a pretty good contracture. That's probably why I started a little bit here, and I did have to make a little small release. You can see the result. You still have to be able to add things to it if you need to. If you need to do an Aiken, if you need to do a different, enough release, whatever you have to do to make sure that you've kind of realigned the rotational aspect of these deformities. Because I think when you're able to do that, if you get a good alignment, if you get union across here, and this is balanced, then I think your recurrence rate is going to go down substantially. So this is just showing the case she's had. So very happy patient. So in looking at some of these conclusions would be that I found it to be an excellent device, and it's for me is addressing some of the aspect of a Lapidus in terms of being able to my goal was hopefully to be able to weight bear these patients with a low profile type implant that would do the things that we need to do in terms of realignment, compression, stability, and once again with the benefit of early weight bearing. We're still going through that to see what limits that we can push, what seems to be the right amount of time to keep them non-weight bearing versus early weight bearing, and how much do you got to protect them. I still think you need to protect them. It's just a matter of what time frame you're going to use and feel comfortable with, and everybody's going to have that different comfort level. But I've been very happy with the results that I've had. And I kind of open that up, Alfred, to any of the questions that some of the guys might have, guys, girls out there.
Yeah, absolutely. So in terms of the Lapidus procedure overall, or your joint prep, do you feel like the nails construct has changed the way that you do Lapidus overall, or changed how you do your joint prep? Like, are you considering more so the surface area congruency, or you like the use of our cut guides? Any of that, has it changed the way you've done Lapidus?
I think in some ways it has, in that I'm not doing as much of the wedge cuts as I used to do. When you do a wedge cut, it adds let's say the speed of the case is a lot faster, right? But once again, I just kind of worry about shortening that met too much. I think there's ways that we can kind of get down to that subcondylar surface, get past that hardened subcondylar surface, and be able to put the nail in. So I think it's changed a little bit of that, in terms of my joint preparation. It's probably also made me pay a lot more attention now, and I think everybody is, to rotation. There's sure, and like I said, the verdict is still out. I think with a lot of these cases, I think there's certain cases that I'm doing with Lapidus that I could probably be doing promo. Okay, and vice versa too. It's just a matter of really understanding like where that instability is coming from through the medial column, like where it is, and maybe the promo itself will have some stabilizing effect on the first TMT joint because of the position change.
Sure. And when you talk about rotation, and obviously promo is a big thing, but with promo, you're taking rotation angle pre-op. Are you taking any pre-op measurements for your Lapidus to look at any coronal plane deficiencies or deformities before you're doing your Lapidus to know how much you need to address the rotation?
I've been doing not preoperatively, other than just judging the degree of pronation that I see when they're weight bearing. I guess so there. Kind of.
Yeah, you sound really far away. Did your AirPods die?
So one of the things I'll say is I haven't objectively done that. Trying to get so that the sesamoids are lined up under fluoroscopy, even though it's a non-weight bearing. But I think even with the guys that are doing a lot of the promo too, I think that angle of rotation, they're kind of just judging that. You know what I mean? Whether
Sure.
you're kind of looking at it, just judging. I think what I'd like to do for the future is we have now like a weight bearing CT scan in our office, and I think that's going to be a very valuable tool in terms of us understanding a lot of these conditions, and with true weight bearing, and be able to look at global points to know what objectively what that rotation is, and is that rotation truly coming through the first TMT joint, or is it coming somewhere else through the medial column, or at least the percentages. It might be coming through different areas of the medial column.
Okay. Awesome. And with this procedure, how long is this taking from incision to close compared to your plate and screw construct?
It's about a little under an hour. Once you got it down, your team and you got your scrub tech understands and is able to kind of get everything set up. It's taking me a little bit under an hour to do. Once, like any other procedure, with like any procedure that you start with, it's going to be long. It's going to take longer the first few times. Okay, and you're going to pick up some of the pearls as you go. But I think it's fast. It's a little faster than the plate and screws.
Okay. And do you feel what are the soft tissue structures that you're worried about here, or if any? I know it's no prominence at all, but in terms of inserting like your medial screw, if it does happen to impinge on your ATT, or the insertion of the nail, are you concerned about the positioning of the EHL dorsally? Is there any consideration with that?
Those would be the two that I would say is that when you're making your approach let's say the proximal aspect of the approach and incision, when you're trying to put the threaded pegs in, is the anterior tib, right? So you're kind of staying just above the anterior tib. So that's typically where like you're retracting the anterior tib plantarly, that superior border of it. If you have to, sometimes you don't even see it. You're okay. On the when you're making putting your guide pin in, and when you're drilling at the proximal first, you got to watch out for your EHL. So you can make sure that your assistant is retracting the EHL out of the way.
Okay. Any considerations with placing the sphere wire? And obviously you're doing that percutaneously. Is that the only percutaneous stab incision that you're making is for that sphere wire, or are you also doing your proximal pegs?
That's the only one I'm placing that percutaneously. The spherical wire. The other ones the pegs I've just extended the incision proximally so that I'm able to retract and be able to get the pegs in proximally. Sometimes you have to retract a little bit, harder, just to kind of just get the sleeve past the skin. And once you got that past the skin, then it should slide in. I don't know if other guys are doing. I don't know if Dr. Houghton or Dr. Tom Chang is doing it with, if they're making percutaneous proximally. I'm not sure.
I think especially some surgeons do those percutaneously, just trying to minimize their incision overall, but it's done either way. There's really no gold standard. It's really dependent on patient.
Yeah, so I'd have to ask some of the other guys too, like Jim Clancy's done a bunch of them too, see if he's doing them percutaneous at that level, But I think a lot of
and have you
be able to be done percutaneous. Like I think the joint prep and everything, you'll be able to make a little incision to put a distracting, some type of something similar to Hinterman, or where you can distract, and I think you'll be able to do that joint prep through a very small incision. And all these other where they're putting the guide pins in the drill, I think a lot of that could be done percutaneously.
Yeah,
which would be great for the blood supply.
It facilitates a percutaneous procedure. And have you used this with let's say a revision with a bone graft quite yet?
I have not. I've done a lot of the bone grafts, like in wedges, for the plate and screws, right? But I haven't used it yet with the nail. I was a little concerned to use it, even though I'm sure you can. I know other guys have, just because I just didn't want the graft to split.
Sure, understood. And is there any reason why you would change your weight bearing protocol? I know you try and put them in a walking boot at about 2 weeks, right when that incision starts to heal. But are there conditions where you would change your weight bearing protocol to say 6 weeks or longer?
I think maybe obviously if you're doing somebody like if it's a diabetic, or they have some regional vascular issues, right? Those sorts of things, or maybe even if had even a history of non-unions in the past, there might be something intrinsically altered with their bone formation and generation. So those would be instances, I think, that I would probably keep them longer non-weight bearing. Also, maybe if it's in combination with another procedure, like you're doing. I've used these, in people that have done flat foot, posterior tib type cases, as a component to the posterior tib correction, or let's say a flat foot correction in combination with the first TMT instability, or they also had a hallux valgus that was symptomatic that we were going to correct at the same time. So those sorts of instances.
Okay. I think one of the last questions that I received was when you're throwing your K-wire at that 23 millimeter distal mark, you mentioned obviously how important it was to get it 23 millimeters and not skive proximally. Do you do anything to prevent skiving besides obviously the tip is built not to skive, but do you make a mark there with your K-wires and then just kind of start that way?
Yeah, I'll usually make like a little tiny pilot, like a little pilot hole. So prior to maybe even placing it in the drill sleeve, I'll take the very tip of that wire, where I made my mark, and I'll kind of, almost perpendicular to the metatarsal. I'll just kind of core out a little bit of the cortex, and then I'll put it into the drill sleeve, and that way it seems to not skive.
Okay. Great. Well, I think those were all the questions that came through from what I'm seeing here. So I thank you very much for taking the time, Dr. San Giovanni. It was really helpful, and I think this is great. And to all the surgeons that joined us tonight, thank you so much for listening in. And obviously, if you have any questions, you can talk to your local sales reps, and if anything needs to be escalated, they can send a message to myself or Jim Edson, and we can kind of go from there. But again, thank you so much, Dr. San Giovanni, for your help.
You're welcome. You're welcome, Alfred. And any of you, if you're doing your first one or something like that, or even the reps too, I'm always available. So like any of the docs out there, like I said, if you want any advice or something like that from somebody who's done a bunch of them, I'm always here. Okay.
Okay. Well, thank you so much, everybody, and we hope you have a great night.